Welcome to Ultrasound-Guided Vascular Access. I'm Matt Lyon. Our learning objectives are to describe the benefits of using ultrasound for vascular access, to describe the two methods for accessing a vessel using ultrasound guidance, to state the common mistakes in each of the two methods for ultrasound-guided vascular access. Ultrasound-guided vascular access has revolutionized central venous access. Compared to the landmark technique, ultrasound has been shown to decrease complications, decrease infections, decrease time to access, and improve patient satisfaction. These are all really big improvements over the blind or landmark technique. An example of this is in the subclavian vein, where we see that the first attempt success rate is 76% when using ultrasound guidance for vascular access, and the overall success rate is 96%. When you include people who have not performed many central venous access procedures, the use of ultrasound guidance has shown that it increases success rate from 44% to 92%, which is a major improvement. For the internal jugular vein, we look at a complication rate for the landmark or blind technique from 5 to 10%. The ultrasound decreases complication rate by 78%, and you decrease the need for multiple catheter replacements by 40%. The equipment you need for ultrasound-guided vascular access is very similar to what you need in the blind or landmark technique. We will not be covering the kit, the needles, and catheters associated with the kit. All we're going to cover is how to do the ultrasound portion of putting the needle into the vein or the artery. So for this, you will need an ultrasound machine. Ultrasound machines have lots of transducers. For the ultrasound-guided vascular access procedure, we'll always use the linear or flat-face transducer. As you can see here, it produces a nice square or rectangle image, and the needle placed underneath the probe will be a nice straight line. You will also need sterile ultrasound gel. For ultrasound-guided vascular access, when we're talking about a central vein, we always use a sterile technique. If we're doing a peripheral vein, we will use the aseptic technique. The majority of this lecture is concerning central venous access or arterial access, so all the procedures you see here are done under sterile conditions, even if the pictures do not show that. Much of the gel you run into in diagnostic practice is not sterile, so you have to find sterile ultrasound gel. Luckily, it's almost always included with the other component of this, which is the sterile sheath. Sterile sheath is an important component of the ultrasound-guided vascular access procedure. The sterile sheath allows you to put your probe in contact with the patient while maintaining a maximum sterile barrier. You could use something like a surgical glove as we see here. However, as you will notice, the cord of the ultrasound probe is in the sterile field. Here we're placing the sheath onto the transducer. Open up your sterile sheath into the sterile field. The person, you can imagine, has been wearing a sterile drape and a sterile gloves. He puts the sterile sheath onto his hand and places gel in it. You have to have an assistant help you put on the sheath by reaching across into the sterile field but not touching, and pulling the sheath all the way out of the sterile field. When you do this, then the sterile sheath is from the tip of the probe all the way outside the sterile field, and the cord will not contaminate your sterile field. Let's look at it once more. You must use gel on the inside of the sterile sheath. So he makes a little pocket, he places a little gel inside the sheath, and then he grabs the probe. Once he's done that, he can secure the sheath to the probe by using a rubber band, and then he uses the rest of the sterile gel onto the patient's skin. Another important issue is how to set up your machine. Generally, you want to set up your machine so that the bed height is very comfortable for you. As we can see here, our sonographer has her elbow rested on the bed so that she is very comfortable and she does not have excess movement of her hand or her arm. She is not craning her neck over or bending her back, so she will not get tired even if the procedure takes more than a few minutes. You also need to place the machine so that it is directly in your line of sight. So in the picture here on the left, you can see that she has to turn her head to look at the image and then turn her head back to look at her hand. When she does this, she is going to inadvertently move the needle. In the other picture, we can see that she looks down at her hand and then back up to the screen. Down at her hand and back up to the screen in a single plane, thus allowing her not to move her needle hand when she's turning her head to look at the image. So try and put the machine where you can look down at your hand and up at the machine. This may mean that your machine is at the foot of the bed. It may mean it's on the opposite side of the bed. It may mean it's at the head of the bed, depending on what area you're using this. Also, hold the transducer as low as possible. You want to hold your hand so that you're touching the probe face as well as touching the patient. Now, there's two methods of imaging a vessel. They are called transverse, where the probe is perpendicular to the vein and the vein looks like a circle, or longitudinal, where the probe is parallel to the vein and it looks like a tube or a pipe. In the transverse, the vein will appear as a circle on the screen. As we move the probe from 1 to 2 to 3, we can see how the vein moves in the tissue. So we have to sweep our probe from side to side or slide our probe up and down the vein to see how it's moving in the tissue, because we're only looking at very small cross-sectional slices of the vessel. In the longitudinal view, we see the vein as a thick line. When our probe is directly over the vein, we can see the vein in its course entirely. If we're off on one side or the other, though, we do not see the vein at all, and it seems to disappear. No matter how we're going to end up looking at the vessel, we always start transverse. We do this for a variety of reasons, one of which is that it allows us in the compression technique. When we place our probe across the vessel, we will always see the vessel because it is a cross-sectional slice of the anatomy, so therefore, if the vessel is there, we'll always see it. The other hand, if you use long axis, you could be off on one side or the other and not see it. So we always start off cross-section because we can identify the vessel. Then we push down with the probe, and when we push down with the probe, veins are low pressure, so they collapse very easily. They look like they disappear or wink. Arteries will collapse if a higher force is used than the arterial pressure, but they will also pulsate when the systolic pressure exceeds the pressure being placed by the transducer. And nerves and thrombosed vessels do not compress at all. So using this method, we can tell the difference between a vein, an artery, and nerves. Because veins will collapse very easily with pressure, we can tell them very readily. Now, if you're doing a venous vascular access technique, you should not cannulate anything that does not collapse very easily. Here we see the common femoral vein, the saphenous vein, and the superficial and deep femoral artery. As we press down with the transducer, we can see that the superficial and deep femoral arteries are collapsing. The common femoral vein and the saphenous vein are not collapsing. Therefore, there is something wrong with this vessel, and in this case, they are thrombosed. So we would not want to use these for vascular access. Now, since we can look to see where we're going to go with our needle and our catheter before we actually stick the patient, we should look to see where the best site is. So we put the probe on the area we're interested in looking at, and we see these two vessels. I have not done the compression technique here, but I'm going to tell you they're both veins, so they're both appropriate to use. If you were going to choose between these two veins for vascular access, which one of these two would you choose? Well, I would choose the superficial, bigger, larger vein, right? It's an easier target because it's closer to the skin, plus it's a bigger target, so it should be easier to do. So before you go and get draped up and get your patient ready, go look to see where the best site is, because the right IJ may be 2 or 3 times larger than the left IJ, and so the right IJ may be the more appropriate vessel for you to use. Also look up and down the vein. So here we're sliding up and down the vein, and as we slide, we can see that the vessel is bifurcating here. And because it's bifurcating, when we feed our catheter or our wire, we may get hung up on the bifurcation. Therefore, we may not want to use this bigger, larger vessel that was superficial because it has a big bifurcation in it too. So we may want to go with a different vessel. So look to see where your catheter is going to go before you even stick also. Now, the general technique for vascular access using ultrasound is similar no matter if you're doing an artery or a vein. The procedure is all the same. The procedure is called the same as the method of imaging the vessel, so transverse or cross-section, or longitudinal or long axis. We're going to cover the general technique now. So no matter how we're going to end up doing it, we always start in transverse or cross-section. This allows for two things. One is identification of vessels. Two is identification of veins versus arteries versus nerves. Here we can see we're pressing down with the probe, and we have 2 veins and an artery. And we know that because the veins are collapsing very easily, and we know that a vein collapses easily, so that's the vein. For the transverse approach, we place our probe across the vein or across the area of interest. Once we identify the vein, we place our needle under the long face of the probe so that our needle will also be in cross section. And when we do that, we will see a cross section of the vein, so the vein looks like a circle, and our needle, because it is also cross section, will look like a dot. Veins are filled with fluid, so they will be black or hypoechoic, and they generally have a bright wall around them. And a needle will be bright because it is made of metal, so that it will be hyperechoic. Here we see a needle about to enter a vein and a needle that has already entered the vein. Now with transverse approach, we must move our probe up and down the vein to see how the vein courses in the tissue. We must use the individual cross-sectional slices or CT scan slices to build a 3D mental image of what the vein is doing in the tissue by sliding up and down the vein. If we do not move the probe, the image of the vein does not change. The same thing with the needle. We must move our probe to see how the needle is advancing in the tissue towards the vein, and if we do not move our probe, we don't see the needle tip any longer, we see the needle shaft. This is very, very important. We must move our probe in the direction of the needle to be able to see the needle tip rather than the needle shaft. We really don't care where the needle has been. We want to see where the needle is going. So let's look at a schematic on this. So we place our probe across the vein. We see the vein as a circle. It is deep in the tissue, so it's towards the bottom of the screen. We take our needle and we place it as close as we can to the transducer, just under the long face of the transducer. And when we do that, we see the needle tip appear at the top of the screen. If we place the needle too far away from the transducer, we would not see the needle tip because the needle has not come into the field of view of the transducer. So we have to place the needle very close to the transducer, as superficial as possible, and we'd like to first see the needle at the very top of the screen. Once we've identified the needle tip, we slide the probe up the arm until we cannot see the needle tip anymore. Once we can't see the needle tip anymore, we know we are beyond the needle tip. Then we slide the needle towards the transducer, and when we do that, the needle will appear, and it will appear to be deeper on the screen because it has gotten deeper into the tissue. As soon as we see the needle tip, we know that that is the needle tip because it's the first thing we saw come onto the screen. And so we know we need to stop sliding our needle because we're looking at the needle tip. Now, we can redirect our needle towards the vein if we need to, if we're off on one side or the other. In this case, we're very well lined up. So we're going to slide our probe again till we can't see the needle tip. Then we're going to slide our needle tip into view. So we slide our needle, and here's the needle tip coming into view. It's almost going to enter in the vessel, but let's try and see the needle go into the vessel itself and not guess that we've gotten into the vessel by knowing that we're lined up. So we're going to slide our probe again. We can't see the needle tip. Now we're going to slide our needle again, and when we slide our needle again, we can see the needle tip come into the vein as it comes into the field of view of the transducer. So let's look at an example of this. This is using ultrasound phantom. Here we see a vein and a needle. He's exaggerating his movements to show you that he is moving his transducer up, and then he is sliding his needle tip into view. So here comes the needle tip. As soon as he sees his needle tip, he slides the transducer up. Now he's sliding his needle into the vein as it comes into view of the transducer. He's going to show you that he is actually in the vein, even though he knew he was in the vein by looking at it. So let's look at this one more time. So we have our probe across the vein. We've done our compression technique. We see our needle tip. We slide our probe till we can't see the needle tip any longer. Now we slide our needle tip into view. Here it is. As soon as we see our needle tip, stop moving the needle. Move the probe. Now move the needle. It's probe, then needle, probe, then needle. You never slide the needle without moving the probe first. On the transverse approach, only a cross-section of the needle is seen. If you move the needle without advancing the probe, the needle tip will not be seen. The needle will look like it's stationary despite you advancing the needle deeper into the tissue. This is because you're looking at the needle shaft and not the needle tip. All right, so let's see what that looks like schematically. Here we've started off the same way. We've identified our vessel. It's deep in the tissue. We've lined it up. We put it in the center of the screen. We put our needle under the center of the probe, as close to the probe as we can get it, and we've gotten it very superficial so we see the needle tip and cross section at the top of the screen. Now we're going to advance our needle without moving the probe, and when we do that, the image does not change. The reason the image does not change is because we're looking at the needle shaft instead of the needle tip. So we've stuck our needle all the way into the skin and the image did not change. So then we decide we're going to slide our probe down and look for the needle tip. And we may have gotten lucky and we may have hit in the vessel and we may get a flashback in our needle. That may occur. But what is more likely to occur is that you're going to pass through the vessel and you will go out the back wall. And when this occurs, you will not be able to feed your wire, you will not get any aspiration. This is a common occurrence when people first start using ultrasound guidance for vascular access. They are able to get blood back into their syringe, but they cannot feed the wire. And the reason is they did not see their needle tip in the center of the vein. Their needle tip went out the back wall of the vein and they're sitting in the soft tissues. This in itself is not that big of a problem because you can pull the needle back into the vein and feed your wire. However, there are other structures posterior to the vein many times, and they could be the artery, and you could have gone into the artery thinking that you're in the vein and then feed your wire and your catheter into the artery, which could be devastating. Here we see an example of this. Notice the carotid and the IJ, and we see needle movement. We cannot tell if this is needle tip or needle shaft. I can tell you that this is needle shaft. The needle tip is very deep in the tissue because this needle has been hubbed and it's about a 4 centimeter needle, whereas the IJ here is only about 1 centimeter deep. So you can see that the anterior wall of the IJ has been punctured and the posterior wall of the IJ has been punctured. They did not push their probe down the vein to see the needle tip come into view. They advanced their needle without moving the probe and they have lost the needle tip. Now they are starting to pull the needle back into plane of the ultrasound image, which is looking at the vessel, and here comes the needle tip here. The other approach is the longitudinal or long axis approach. Here the probe is placed over the vein in cross section as we discussed before. We identify the vein and we use the compression technique. Then we rotate our probe so that it is parallel to the vein. Once we've identified the vein and long axis, we place the needle under the short face of the probe, and we also see the needle and long axis. The most difficult portion of this is rotating from the short axis position to the long axis position without losing identification of the vein. But once we've done that, we see the vein is a thick line and the needle is a thin line. The vein will be filled with fluid, so it is hypoechoic with bright walls, and the needle will be hyperechoic because it is made of metal. And we direct the bright line, the needle, into the vessel, and that's all there is to it. Again, rotation is the most difficult part. Here we have identified our vein, and we are rotating our probe from cross section to long axis. So the vein goes from being a circle to being a tube or a pipe. Let's go back to what we were talking about before. If you're directly over the vessel, we see the vessel in long axis. But if we're off on one side or the other, the vein disappears. So if you lose the vessel when rotating from short axis where you've identified the vein to long axis, if you lose it, you cannot do the compression technique in long axis because you could be collapsing the vein and it's disappearing, or you could be sliding off of the vessel and it's disappearing and it's not really a vein. So we only do the compression technique in short axis. Then you must keep the vessel on the screen the entire time as you're rotating from short axis to long axis so that you know the identity of the vessel in long axis and you're assured that it is a vein. Now you have to remember that the beam coming out of the transducer is about as thick as a sheet of paper. Therefore, if you're directly over the vessel, you will see it. But if you were a millimeter to one side or the other, you may not see the vessel. So therefore, when you rotate the long axis and you've got the vein lined up and you place your needle underneath the transducer, you may not see the needle because the needle may not be in the thin sheet of paper beam. It may be off on one side or the other. So you have to go identify your needle, decide which side of the vessel it's on, and then redirect it back into the vessel. So let's see an example. Here's a vein. We've already done our compression technique and rotated. We can see the needle is coming in, but we can't identify the needle. It's on the other side of the screen. So we know that, so we redirect it back in towards the plane of the beam, and as we do that, the needle becomes brighter and the tip becomes brighter. Whenever a circular or a tubular structure is underneath the transducer beam, when the walls are bright, as we see here, then you know that you are perpendicular to the structure. In other words, you are directly over the center of the vessel. The same thing for the needle. When the needle tip is very bright, it means that you're looking over the very center of the needle tip. You're looking at the very center of it. So when the walls are bright and the needle tip is bright, you know that they're in the same plane of the ultrasound beam. We see the vessel here. We can see the needle movement, but we don't see the needle tip. It's on the other side of the screen. So we redirect the needle back in towards the screen, and as we do that, the needle tip becomes very bright, and now it's sitting right in the middle of the vessel. So which technique is better? Well, in the transverse or cross-section technique, you can see the needle the entire time, but it's easy to mistake the needle shaft for the needle tip and cause iatrogenic injury. In the long axis technique, you see the needle as it advances towards the vein, and you can see the needle in its entirety. However, this is a difficult technique for most novice users to master, particularly in human tissue. We use a mixture of both techniques to avoid the disadvantages of each of the techniques alone. This mixed technique, you start off in cross-section or transverse axis, identifying the needle, and walk it down in a stepwise fashion towards the vessel. Here we see the vessel in cross-section as well as the needle. We've done our vein identification compression maneuver. Now we advance the probe, then the needle, just like we did before. As we approach the vessel and we're just above it, we switch from a short axis to a long axis technique. We know that the needle has localized the vessel, so we don't need to worry about whether we're actually looking at the artery or the vein. In this case, we know we're looking at the vein because the needle points right at the vein. Then we finish off the cannulation in long axis, where we can control the needle tip and prevent it from going through the posterior wall of the vein. This is a much better technique because it gives you control over the needle tip. Here we are in a phantom. We're going to start off in cross section or short axis. We're going to use a stepwise approach, taking the needle right down towards the vessel. Here we are getting right to the top of the vessel. We know that the needle tip is right above the vessel, so that when we place our transducer in long axis, we can see that the needle tip is right above the vessel, and we can advance the needle in long axis, avoiding posterior perforation. Again, this allows very good control of where the needle ends up in the vessel. In human tissue, you can see here in the cadaver, the needle is often very difficult to visualize in cross section. While we know that this is the vein we want to cannulate, we can see that there's movement of the needle tip above the vein. This makes it very difficult for us to know exactly when we enter the vein. In long axis, we see the needle and the vessel much better, and we can see the needle as it slides into the vein, and we avoid that posterior perforation. Again, this mixed technique takes advantages of both of the two techniques before, but it avoids the disadvantage, and this is the one we recommend. So let's look at some examples at various locations. The internal jugular vein is probably the best site for ultrasound-guided vascular access when you're looking for a central vein. The IJ is very superficial. It's very easily visualized, even by novice sonographers, and the catheter placed in the IJ is very well tolerated. So this is probably the easiest to perform and the best to learn initially. Here we have an example. We're going to look at a simulated patient and a simulated catheterization. We're looking at the patient's neck. Here we see the EJ vein. That is not what we're going to be cannulating. What we're cannulating is the IJ vein, which is deep to the EJ vein. So we place our transducer or probe across the patient's neck, and when we do that, we identify the IJ. The IJ will be a circular structure. It's generally not as circular as the carotid as we see here. And it also pulsates with respirations and atrial contractions. We've turned long axis, and then we place our needle under the short face of the probe. Here we see the IJ and the carotid deep. Here's our needle coming into view, and we stop our needle before it goes through the posterior wall and into the carotid. Again, I told you long axis is safer because you always see the needle tip, and you can see why in this example, because it would have been very easy to slide through the IJ and into the carotid and cause a complication. One more time, we place our probe across the neck. When we do that, we are looking for the IJ. The IJ is very easily identified by its pulsations. It actually pulsates more than the carotid artery. We've turned long axis, keeping it on the screen the entire time. We know that this is the IJ. Now we see our needle coming into view. The IJ is in long axis, the carotid is long axis, and here's our needle coming into long axis, and we stop it in the center of the vessel. The subclavian vein is a vessel that is touted to be the best location for placing central venous access. The axillary vein comes up from the arm and then courses underneath the clavicle and changes name to the subclavian vein. We are going to be puncturing the axillary vein. Now here in this picture we can see the clavicle is a bright echogenic line and then shadowing beneath it. And if we place our probe or our transducer in an up and down position on the body, right at the curvature of the clavicle, we will see the artery coming out from underneath the clavicle, and the vein has already come underneath. Deep to that we can see the first rib and the pleura. Here's an image of the anatomy. We see the clavicle. As we slide out from the clavicle, we can see the vein and the artery falling behind. We just passed over the first rib, and now we're heading out towards the axilla or the arm. Now we're coming back. See the first rib. We'll turn long axis over the vein, keeping it on screen the whole time. We can see the rib and the pleura beneath. Notice the distance from the axillary vein to the lungs. Here we go again. As we slide out towards the arm, the axillary vein will bifurcate, as we see here. You can use either one of these bifurcations and feed the catheter in towards the heart. Either one will work. We've turned long axis on the vein, and the artery is not in view. Here's an example of cannulation. You can see the vein is now in long axis. Here's the needle coming in long axis. Notice how resilient the anterior wall of the vein is. It does not want to be punctured. So this person is pushing fairly hard on that anterior wall and it won't puncture. Luckily they're looking at it with ultrasound so they can tell that this is happening. Otherwise they may be frustrated by the lack of blood and think that they're in the wrong place and move to another site, meaning move to a couple millimeters over, and instead of getting the vein, which we are over here, they may actually stick the artery by accident. They pop through the anterior wall and actually come through the back wall. This is a common occurrence in the blind technique, and when that occurs, you cannot aspirate blood and you think that you're in the wrong place or that the vessel is something wrong with the vessel. When in actuality, it took so much force to go through the anterior wall that you went through the posterior wall at the exact same time. They pull their needle back into the vein, and now they're ready to feed their catheter. So once they feed their catheter, we can see their catheter coming in here, and we can see that it is in the vessel. So in conclusion, ultrasound makes vascular access safer, more efficient, quicker, and is the standard of care in many settings. Short axis approach is technically easier to perform, but the needle tip can be lost if the probe is not advanced before the needle. Always advance your probe, then bring the needle into view. Probe, then needle. Probe, then needle. If you're having trouble feeding your catheter or your wire, it's because you're going outside the back of the wall of the vessel and you're not following the needle tip into the vessel. Long axis approach is technically more challenging to perform, but is generally safer than the other approach. Therefore, you really should know both, because many times you can only use one approach or the other. I generally use the long axis approach on most central venous access. I use the short axis approach for superficial vessels such as peripheral veins and the radial artery. Thank you. Appreciate your time. Again, this is Matt Lyon, Ultrasound Guided Vascular Access.